All right, I have the pleasure of introducing Dr. Sam Malnik. He's our PGY3 resident from Barrow. He went to college at Amherst College. He then went to medical school at University of Florida College of Medicine or School of Medicine. And now he is at Barrow. We had a really wonderful time the last couple of months. He's got a little bit more time left, but he's going to be giving us a talk on neurosurgical intervention for community-acquired intracranial infection.
Thank you, Dr. Roniker. Good morning, everybody. As Dr. Roniker mentioned, I'm Sam Malnik. I'm one of the 30 residents at Barrow with an interest in endovascular neurosurgery as well as acute care neurosurgery. Today, I'll be talking about neurosurgical intervention for community-acquired intracranial infection, which is a topic that grew of significant interest to me over the last 2.5 months that I've spent at PCH. So I don't have any disclosures. Objectives of this talk are first to review the pathophysiology of community-acquired intracranial bacterial infection. Next, we'll discuss the role of neurosurgical intervention in the management and treatment of meningitis and ventriculitis. We'll then assess the function of intraarterial treatment for infectious vasospasm. And lastly, we'll ponder some of the operative techniques for the treatment of subdural empyemas. So this topic really became of interest to me during my first month in the PICU. And being a BNI resident, we're very used to a number of acute neurosurgical conditions requiring EVDs, mostly being subarachnoid hemorrhage from ruptured aneurysms, IVH, as well as obstructive hydrocephalus. And while these conditions are certainly also prevalent in the pediatric population in the PICU here, I became particularly interested in two patients that I assisted in their care during my first few weeks here. In the image on the left is a teenage boy with strep pneumoventriculitis who had quite the prolonged ICU stay with us. And then the image on the right is a teenage girl also with strep pneumo intracranial infection, but she was suffering from meningitis with multifocal infarcts and would spontaneously blow her pupils. Both of these patients ended up with EVDs shortly into their PICU stay, which set me on this path to look into the treatment of these intracranial infections in more depth. As we all know, pediatric acute bacterial meningitis is a rather prevalent condition, mostly in neonates, but is also has an incidence of about half to one case per 100,000 children in their teenage years. The bacteria that are responsible for this are quite common, that being strep pneumonia, Neisseria, and H flu. Both of these three bacteria being responsible for both the young pediatric version of meningitis as well as meningitis in adolescents in the later teenage years. As we're all familiar with, acute bacterial meningitis is certainly a concerning intracranial pathology in the short term, leading to seizures, focal neurologic deficits, prolonged ICU stays, and even death. And then in the long term, over the course of months to years, children can suffer from hearing loss, cognitive impairment, hydrocephalus, as well as epilepsy. The pathophysiology of acute bacterial meningitis is still rather vague and not completely understood. Typically, these pathogens invade the CNS through a hematogenous route or by direct extension from erosive sinusitis or roaring mastoiditis. We see proliferation of the bacteria within the subarachnoid space, which triggers a robust immune response, causing the migration of leukocytes and the release of cytokines and chemokines. Where the neurosurgeon becomes involved in the treatment of these infections is typically the sequelae of inflammation, namely increased intracranial pressure and diffuse cerebral edema, as well as symptomatic vasospasm. And while vasculitis and metabolic derangement certainly are sourced from this inflammation. Unfortunately, we don't have great neurosurgical treatments for them at this time. The etiology for elevated intracranial pressure and acute bacterial meningitis is diffuse. What we believe occurs is a multifocal inflammatory response that results in thrombosis and venous congestion, impairment of the blood-brain barrier, loss of autoregulation, as well as hydrocephalus and interstitial edema, all combining for elevated intracranial pressure, which compromises cerebral perfusion pressure. When we think about elevated intracranial pressure, it pretty quickly we have to think about a rationale for invasive monitoring of these patients. And through the literature, we know that a low presenting GCS constitutes a high mortality rate in acute bacterial meningitis, giving us the justification to move forward with more invasive interventions, such as the placement of an ICP wire or the placement of an external ventricular drain. Also, numerous retrospective reviews have found that higher ICPs was correlated with higher mortality rates, supporting the justification for invasive monitoring. We know that high ICPs decrease intracranial blood flow, which leads to tissue infarction as well as herniation syndromes. And as we've seen over the last 2 to 3 decades, a broad neurocritical care approach has been brought to the treatment of severe TBI, mainly based off of the ICP targeting. So this is now a multimodal modality that we have for the treatment of severe TBI. It's reasonable to apply it also to other conditions associated with high intracranial pressure, like this treatment of severe acute bacterial meningitis. And my first question when looking into this topic was, is non-contrasted CT head an adequate surrogate of ICP in these patients? And what I found was interesting to me that throughout the literature, the CT head is a poor predictor of ICP and acute bacterial meningitis. This first article by Larson et al. Was a 10-year follow-up of patients at their facility that had ICP monitoring in the setting of severe acute bacterial meningitis. Patients that were typically adults with a GCS of under 9. The most common pathogen, unsurprisingly, was strep pneumo. And what they found over the course of this follow-up of 10-year follow-up of these patients was there was not a strong correlation between signs of elevated ICP on CT scan and the ICP measurements that they got while in the ICU. In this review published in the Neurocritical Care Journal, we found 5 additional studies that confirmed that CT was less reliable and severely underestimated elevated ICPs. Their finding was that once there's an abnormal CT head finding, outcomes are already worse, even when there's not a clear correlation between the ICP finding with the CT head findings and the ICP measurements. This was a particularly interesting case series published in the early 2000s about the issue being that CT scans lack the temporal resolution to determine when ICPs are actually elevated. So they presented three cases in this paper. This is one of the figures from the paper. If we look at image B, or image A is an adult patient that came in with strep pneumo meningitis. In image B, you can see slight effacement of the sulci and the appearance of some early loss of gray white differentiation. However, I don't think any of us would look at the scan and say, this is a patient with elevated ICPs in the setting of these open sulci in these basal cisterns. But in this image, B and C, the patient's actually comatose. Image D occurred 70 minutes after images B and C. Now the patient has clinically herniated, yet we don't really see effacement of the sulci in image E. I'm sorry, effacement of the cisterns in image E, even though we see effacement of the sulci in image D. However, in this image, the ICP is actually 90. Once again, I don't think any of us would predict such a malignant intracranial pressure monitoring based off of this image. 11 hours later, the patient is essentially deceased with loss of gray-white differentiation. And this is a similar story that happened in 2 other cases in their series. where patients underwent intracranial pressure monitoring in image B and in image C. And while you see some edema, in neither image do you see real cisternal effacement or concerning for herniation syndrome, despite ICPs in the mid-40s. So my next question was, in patients with acute bacterial meningitis that have elevated ICPs, do they respond to drainage and other treatments like hyperosmolar therapy that are the cornerstone of traumatic brain injury treatment? This is a interventional case control study presented in 2014 that had patients that were largely in their late teenage years through their adult years, found to have positive CSF for acute bacterial meningitis with either severely impaired mental status in a GCS of less than 9, or that had elevated opening pressure on a lumbar puncture of greater than 40 centimeters of water. And what they found is in these patients that either had depressed mental status or elevated lumbar puncture opening pressures, they did in fact have elevated intracranial pressure as monitored largely by EVDs. And these values were the pressures after they drained the patient after placing the ventriculostomy in the OR. And despite that drainage, they still had elevated intracranial pressure. These patients, about 52 of them, underwent prolonged ICP monitoring as well as CSF drainage. And what they found is that patients that did have elevated intracranial pressure did respond appropriately to drainage and to ICP monitoring. So the patients, 11 patients who developed elevated brief ICP spikes of greater than 20 for less than 5 minutes, all of them responded to CSF drainage to reduce their intracranial pressure to less than 20. And then patients that had prolonged ICP spikes of greater than 20 for greater than 5 minutes, the vast majority of them responded to conventional treatments, including CSF drainage, the administration of hypertonic saline, and brief hyperventilation in the case of patients that had hyperemia, suggestive that these patients do respond to elevated ICP treatments in a similar way to patients with traumatic brain injury. So the real question, once we determine that ICP monitoring is necessary, that these patients respond to CSF drainage and ICP treatments from the traumatic brain injury literature, is do these patients have improved outcomes? And unfortunately, the data for improved mortality and morbidity from ICP treatment in acute bacterial meningitis is limited. This was the same review that I had mentioned earlier, a 2024 review published in the Neurocritical Care Journal of 18 studies consisting of 616 patients of both adult and pediatric age, where 7 of the 18 studies were pediatric studies. And they tried to separate patients that were treated with ICP management, being therapy aimed at lowering the ICP, from treatment of CPP, where you can either lower the ICP to increase CPP or increase the MAP to increase the CPP. And what they found is unsurprising, that ICP monitoring patients typically have longer hospital stays, and that this is particularly apparent in pediatric patients. There was a few randomized control trials, or a single randomized control trial for the treatment of adults with severe acute bacterial meningitis that demonstrated a reduced mortality in a ICP managed group. This was primarily through the use of an EVD. There's really only one impactful study in the pediatric literature. This is a randomized controlled trial of pediatric patients in India that showed when you're managing patients with acute bacterial meningitis and elevated intracranial pressure, a better treatment strategy is to increase CPP as opposed to reduce ICP, but this is only in a single study in India. A few authors have proposed management strategies with this data in mind for the use of intracranial pressure monitoring in suspected meningitis. And unsurprisingly, people have recommended its use only in severe cases, those being patients with a worsening neurologic exam, a GCS of less than 8, non-reactive pupils, and/or radiographic evidence of herniation and mass effect. And I think we can all agree in these patients where you're watching them actively deteriorate in front of you with a high mortality rate, it's reasonable to subject them to invasive monitoring at that point, if not, to improve mortality, but to give us more data points on what's going on intracranially. I do think there's an important distinction to be made between meningitis and ventriculitis, terms that I've seen frequently both here and at St. Joe's used interchangeably, but have different clinical courses and certainly different levels of severity. So acute bacterial meningitis, as I had mentioned, is inflammation and infection of the meninges in the subarachnoid space, diagnosed via clinical signs like headaches, nuchal rigidity, fevers, nausea, and vomiting, with an accompanying CSF profile and culture suggestive of bacterial infection. This is certainly a more common diagnosis than bacterial ventriculitis. Ventriculitis is a subset of more severe infection. It's infection that blocks the ventricular system, leading to obstruction of outflow and frequent hydrocephalus. It's characterized by the inflammation of the ependymal lining on imaging, which on an MRI is indicated by periventricular T2 hyperintensity and thin contrast enhancement, and periventricular hypoattenuation on CT scan. As I had mentioned on my opening slide of my first few cases in the PICU, we saw in the case of a 13-year-old with strep pneumoventriculitis, he had diffusion restriction within the ventricular system itself, suggestive of pus within the ventricles in a gravity-dependent manner. The course of ventriculitis is particularly malignant. When we all see this scan from a review published in 2021, we should immediately think that this is a patient that requires an external ventricular drain in the setting of transependymal flow and diffusion restriction within the ventricles. When we look at the outcomes of ventriculitis, they are particularly poor. Where in this review, also the 2021 paper, we saw that 60% of them were subjected to neurosurgical intervention. And despite that, the in-hospital mortality remains 30%, and the one-year mortality was greater than 40%. Notably, these patients have a prolonged length of stay, where the average patient in this case series had a length of stay of 25 days. So after looking into management of intracranial pressure in the setting of acute bacterial meningitis, I also became interested in some of the cerebrovascular complications of acute bacterial meningitis, those mainly being cerebral vasculopathy. In the pathophysiology of cerebral vasculopathy in acute bacterial meningitis, just like many topics within meningitis, is not fully understood. What we think is occurring is that there's a multifactorial uh, vasculopathy occurring, that being vasospasm, vasculitis, arterial thrombosis, venous thrombosis, as well as delayed intracranial aneurysm formation. The literature shows that this is rather prevalent in the population of pediatric patients with strep pneumo meningitis, where greater than 25% of them are witnessed to have vascular changes. Frequently, this is noted in TCD velocities peaking within the first 5 days and then decreasing over the course of the next 3 to 4 weeks. Interestingly, the pathophysiology of vasculopathy changes over the clinical course of these patients fighting their infection. Early in their course, we believe that the vasostenotic disease is occurring secondary to vasospasm, where the blood vessels are reacting to the pressure of underlying exudate within the subarachnoid space, as well as vasoactive pro-inflammatory cytokines that are being released by the leukocyte migration and proliferation within this space. Next, we see endothelial dysfunction, as well as endothelial cell injury and the death of smooth muscle cells. And then as a later complication, we see late intimal thickening, as well as luminal stenosis that shows less vessel reactivity to medications compared to the early vasospasm that we're seeing in the clinical course. In the approach to vascular stenosis in patients with meningitis is similar to the approach to any vascular stenotic disease, where first we diagnose it via non-invasive diagnostic modalities, including transcranial Dopplers, CTAs, as well as MRI. Notably, the gold standard remains the diagnostic subtraction angiogram, which has a low risk of peri-procedural stroke as a purely diagnostic test, certainly on the order of 1 or less percent. It's been shown in multiple studies that while CTAs and CT perfusion offer a high specificity for the presence of vasospasm, they're limited by poor sensitivity. This has been demonstrated in multiple studies of aneurysmal subarachnoid hemorrhage. An invasive angiogram also allows direct assessment of vessel reactivity, where you can inject vasoreactive medications within during the angiogram that will assess for vasodilation as opposed to vasculitis that may not have reactivity to these medications. The treatments for vasospasm and vasculitis and meningitis largely come from the literature of aneurysmal subarachnoid hemorrhage, those being the administration of nimodipine, permissive or induced hypertension, and euvolemia or hypovolemia. I found this chart to be particularly interesting. This is a study of different medications and different techniques that have been used for the treatment of vasospasm and aneurysmal subarachnoid hemorrhage. And despite a very large patient population and a disease that's been at the high end of neurosurgical interest for many decades, we're still very poor at treating vasospasm and aneurysmal subarachnoid hemorrhage, with the really only evidence for medication improving subarachnoid hemorrhage outcome being nimodipine. A number of theories have been proposed for the treatment of severe refractory vasospasm in both bacterial meningitis as well as aneurysmal subarachnoid hemorrhage. First is administration of nicardipine, also known as Cardine, which is a calcium channel antagonist. Obviously, Cardine is a medication that's widely used in the intensive care unit, given its effects for vasodilation causing hypotension. And the theory being that if you can deliver Cardine into the intraventricular system, you can avoid the downsides of systemic hypotension while promoting vasodilation exclusively within the intracranial circulation. And Sedan et al. In 2021, they found decreased TCDs and improved functional outcomes in over 400 patients with aneurysmal subarachnoid hemorrhage when administering scheduled intraventricular Cardine. And this notably happened without increased incidence of infection. In a paper in 2024, there was a case report of a 12-year-old with pneumococcal meningitis who developed severe refractory vasospasm. And similar to the studies in aneurysmal subarachnoid hemorrhage, they noticed improved TCD velocities as well as resolution of a weakness after a 5-day course of intraventricular Cardine. The second medication that has been theorized to have benefit as an intraventricular treatment is nimodipine, which is, like Cardine, a calcium channel antagonist. What's, extensively noted in both the adult, but in particular the pediatric literature, is the significant rate of systemic hypotension when given children PO nimodipine, this being in a study of aneurysmal subarachnoid hemorrhage. And while we've seen a reduction of delayed cerebral ischemia and vasospasm in aneurysmal subarachnoid hemorrhage, this in an adult population, unfortunately, there's no pediatric literature supporting the use of intraventricular Cardine for either the treatment of pediatric ruptured aneurysms nor for the treatment of meningitis-induced vasospasm. A second treatment that has been proposed for the treatment of severe refractory vasospasm is intraarterial treatments. One of these being verapamil, which is a different class of calcium channel antagonist that's a potent vasodilator. And this is a medication that has well-established vasodilatory effects in the angio suite. But what's become even more interesting is the administration of intraarterial milrinone, This is a phosphodiesterase 3 inhibitor that increases cardiac uh, as well as output, which improves cerebral perfusion. In studies in pulmonology studies, it's also been shown to have an anti-inflammatory as well as an antiplatelet effect that certainly has a benefit when thinking about the treatment of thrombotic complications of microvascular disease. There's robust data for the use of IV milrinone in the treatment of aneurysmal subarachnoid hemorrhage while in the ICU. In 2023, actually, one of my co-residents, Dr. Norman, published a study or a case report out of Cornell where they showed the safety of intraarterial milrinone for the treatment of infectious vasospasm, this one being a case where the patient was resistant to intraarterial treatment of verapamil. In 2024, there was a case series published for a 9-year-old female with pneumococcal vasospasm who was treated with continuous intraarterial verapamil via a intraarterial verapamil, milrinone, and heparin via a catheter that was actually stranded in the cervical carotid. So what happened in this patient was they developed recurrent symptomatic hemiparesis about 2 hours after administration of intraarterial verapamil and milrinone. So they were repeatedly taking the patient back to the angio suite for repeated treatments. They ultimately decided to leave a 4 French guide catheter in the cervical ICA with a continuous administration of verapamil, milrinone, and heparin, and they found, an improvement in their vessel caliber and a symptomatic improvement in their hemibody strength. And certainly, while we're in the angio suite, we can attempt angioplasty with its unique risk-benefit profile for mechanical dilation of a blood vessel. In my second month in the PICU, I was hopeful that our cases of bacterial meningitis and of bacterial neurosurgical problems had ended. And then we arrived at a different type of patient, that with acute subdural empyema. In talking about the pathophysiology of subdural empyema, this is a condition of bacterial proliferation and infection within the space between the dura and arachnoid, where we see a focal collection of purulent material. It has a tendency to spread rapidly through the subdural space until limited by anatomic boundaries, such as the falx, the tentorium, and the skull base itself. Like bacterial meningitis, it's frequently secondary to conditions affecting the ENT realm, mainly sinusitis, otitis media, and mastoiditis, with the occurrence of otitis media in meningitis being more frequently the source of subdural empyema in younger children, as their sinuses have not pneumatized early in development. It's also been theorized that there's retrograde flow of thrombophlebitis through valveless veins within the leading to greater risk of infection proliferating within the intracranial vault itself. Subdural empyema is complicated by cerebral edema, hydrocephalus, venous thrombosis, as well as seizures, and unfortunately death if not adequately treated. A number of papers have been published on the location of subdural empyemas in pediatric patients, where fortunately the large majority of these patients have empyema in the supratentorial space, mostly on the convexity. There is a number of case series that have been published on interhemispheric subdural empyemas, as well as infratentorial subdural empyemas, which are more difficult to treat given their anatomic location. In looking at predictors for an unfavorable outcome in subdural empyema, a couple of factors are noted. One being a low GCS of less than 8, another one being the presence of cortical venous thrombosis as well as infarct. These are all significantly associated with unfavorable outcome. And the takeaway from that is that upfront aggressive intervention is required, that we should not wait for these patients to decline or even develop a small cortical thrombus, because by that point, their fate and negative outcome may already be determined. And I included this picture, just to indicate how amazing it is that this degree of purulent material can actually be present on the convexity of a kid, of an adult before they become symptomatic. It's really amazing what the brain can tolerate, midline shift, cortical irritation before they become symptomatic. So a big question throughout the literature is how do we evacuate these empyemas? Should we go with a larger craniotomy or something smaller, more minimalistic, like a burr evacuation? And throughout the literature, the answers are pretty stable that larger is better for outcome and is necessary. Nathu et al. 2001 published a case series of almost 700 patients in South Africa. They found a significant correlation between a primary large craniotomy and good clinical outcomes. They also found that the rates of reoperation and morbidity increased significantly when performing limited cranial procedures like a burr evacuation. The results of this study were replicated in a paper published in 2009 out of Malaysia, where they similarly saw clinical improvement and better clearance of an empyema when patients underwent evacuation via craniotomy as opposed to burr holes. In the one large study that I found of pediatric patients, published also in 2009 out of India, they found that an initial large craniotomy led to lesser repeat procedures and a slightly better clinical outcome. Over 80% of patients in their case series that had the required repeat surgery occurred secondary to residual after a burr hole as opposed to a craniotomy. The reason that's proposed for the failure of burr hole treatment is that it leads to worse outcome, secondary to brain swelling, preventing adequate aspiration of the purulent material, that there's loculations within these empyemas, that just like a chronic subdural hematoma prevent you from adequately decompressing it, that you may get into one compartment that's loculated, but that you will not get into the larger purulent collection. And also these collections can be quite thick in their consistency. So, when we think about bigger isn't always better, unfortunately, bigger is probably better with the treatment of these subdural empyemas. A particularly interesting topic to me comes in the treatment of these interhemispheric subdural empyemas. And as I showed you in that introductory slide to my second month in the PICU, the one patient that we had that had an operative subdural empyema was actually in the interhemispheric fissure. These interhemispheric subdural empyemas frequently occur as an extension of frontal sinusitis or thrombophlebitis from a sinus infection. And as you can see in these images, the interhemispheric fissure is not an ideal operative corridor. On the top figure, you can see a small interhemispheric craniotomy, and what you're limited by medially is the sagittal sinus, and frequently laterally, you're limited by bridging veins that can go from the cortical vessels into the superior sagittal sinus. And the further back that we go on the sagittal sinus, the greater risk that we have of injuring one of these draining veins, injuring the superior sagittal sinus, and not having an adequate ability to repair or control the bleeding. Frequently, these interhemispheric subdural empyemas have a high treatment failure. And that is because, as I mentioned, we're limited anatomically about where we can open the interhemispheric fissure and about how far anteriorly and posteriorly we can aspirate, at least at the surface, before running into cortical vessels. In a case series published in 2023, half of the patients with interhemispheric subdural empyemas required reoperation. And that was both via initial treatment with limited burr hole operations, as well as large craniotomies. there was a case report published in 2016 about the use of a flexible endoscope for evacuation of these interhemispheric empyemas, with a figure shown in the bottom right corner. And the basis for this evacuation actually comes from the literature of thoracic surgery, where they have found loculations in pleural empyemas that can be accessed via a flexible endoscope by making a minimal incision into the chest and maximizing the coverage and evacuation of the empyema. I would argue, however, that in the interhemispheric fissure, a small injury to a vessel carries, possibly catastrophic consequences if not able to be adequately controlled via an open exposure. This is certainly different than in the realm of a pleural empyema. So in conclusion, there are severe cases of acute bacterial meningitis that are frequently associated with elevated intracranial pressure and significant vasostenotic disease, which contribute to significant morbidity and mortality. The placement of an external ventricular drain carries diagnostic value that currently has greater evidence for its support than the therapeutic value of ICP treatment and CSF diversion in acute bacterial meningitis in pediatric patients. We should have a low threshold for an angiogram in infectious vasospasm, as it produces both diagnostic information for the nature of the vasostenotic disease that we're facing, as well as the blood vessel reactivity for therapeutic interventions. The treatment of subdural empyemas remains a surgical intervention that, despite years, decades of literature, still has a high treatment failure and justifies a large upfront craniotomy over minimally invasive initial treatments. And then lastly, something that we should not have to say, but we're having to say increasingly in 2025, continue washing your hands and get vaccinated. These are my references. So thank you everyone for listening. Thank you for a good 2.5 months. I look forward to the rest of my time here at PCH. I am free to answer any questions that come up.
Hey, Sam, that was a really great talk. Can you hear me okay?
I can.
Okay, perfect. I was just going to ask if in your literature review you came across any papers that were suggesting that there was an increase in the rate of sinusitis and intracranial complications since COVID started. Because we've kind of anecdotally seen that here.
Yeah, I hadn't noticed it. I think one aspect that's a little frustrating about the literature for subdural empyemas, is it really seemed to peak in the 90s and 2000s with improvement in imaging systems. And since then, the literature has really become stagnant. We just accept the fact that there's a high recurrence rate in published case reports, but I haven't really seen any, in my limited review, I didn't see any impactful literature about how it may be increasing. But I could certainly see that being the case in the setting of the post-COVID era. It's interesting to think about, and whether there's also a contribution of decreased vaccination numbers since COVID's probably playing a role as well.
Yeah, hey, Jenny, it's Jay. No, that's actually the same question that I was going to probe. And there is literature on this, Sam. And back in 2021, the CDC got so. One of the things that's really interesting about subdural empyema in neurosurgery is that this is the first time in my career that we've seen a change in incidence in something nationally that everyone noticed and everyone started talking about, and everyone started reporting. And so back in, I want to say 2021, the CDC actually released a call for reports for subdural empyema. And there was a task force that was created because all of the centers were noticing substantial increases in subdural empyema. In fact, Taryn Bragg got a little bit of notoriety in Nevada because she actually approached the CDC back in 2021 with the same report. They investigated it. They found something like a 300% increase. And I don't know that anyone understands why. And maybe you guys know more than I do. We think it's some sort of deficit, like it's like an immunological deficit on the herd level, both from quarantine and decline in vaccination rates. I don't know if anybody else has any thoughts on
Well, it was interesting because Mandeep Tamber from Vancouver gave a talk on this at the ASPN last year and had mentioned that in his conclusion that there was kind of like an oscillation in the rates of sinusitis with empyema. And so he felt like this was just kind of like a high incidence, but it was going to go back down eventually. And then other people have talked about the potential that masks are somehow like changing the flora in the nose, and I don't know, something with the masks.
Yeah, we saw in Seattle about a 300 or 400% increase in subdural empyema in 2022, 2023. And like in my training, these were rare cases, and they're just not rare anymore.
I feel like over my 2.5 months here, I've seen maybe 3-ish cases of them, and all associated with sinusitis. So I guess that's putting us on, schedule for 10 to 20 in a year, which seems dramatically higher than what I was looking at in the literature for the 2000 to 2010 range, certainly.
Yeah, it is, and I mean, when I trained in LA, we'd see 1 or 2 of these a year. So it's that to me is one of the most interesting things about this is the change in incidence.
I just worry about it as a parent of like at what point do you get more concerned that a headache is not just a sinus headache, and then you have to I don't want to be getting a call from DCS because my kid had sinusitis and now has an empyema that needs to be emergently evacuated. It's hard to know when to pull the trigger and get medical attention as a medical provider.
I wonder if there's any increased literature in the ENT world, because, obviously this is something that they would track much more closely with sinusitis. I wonder if looking in the ENT literature, if we would find more information about increased incidence of more severe sinusitis.
So I know that there is a large network study that's ongoing because I think I'm peripherally a part of it, and that there is a substantial increase in reported sinusitis among the ENTs, which is why we're probably seeing a proportionate increase in subdural empyema. And I think Jenny, to your point, it's still on the order of incidence, like every headache is a brain tumor.
Yeah.
It's like low incidence disease. But that to me is like the most fascinating thing, Sam, because had you trained in the early 2000s, you wouldn't have seen any of these. Maybe 1 or 2 a year, like I said. That is to me the most interesting thing.
Yeah, I think it's certainly worth more looking back at our own. We could definitely publish cases from here. I know that there's cases at BNI. Just last week, I was showing Dr. Bristol, and basically a mirror image of that interhemispheric subdural empyema that we treated last month. Mirror image that they did on Thursday or Friday at BNI. And I don't think that these are cases that are, typically coming up twice within a 1-month period between these two institutions. So certainly some research that can be done.
Yeah, the problem from an epidemiologic standpoint is we don't know the denominator. So we don't know the number of active sinusitis. That's a word. I don't know. Just made it up. But the number of active sinusitis cases that don't come to physician attention and don't require treatment, medical treatment. So we have that's unfortunately, I think that's where the CDC struggles too, is that they don't know. They can only look at the number of inpatient admissions and discharges, but they don't know the number of people like seeing their primary doctors and going home on antibiotics or not seeing their doctor at all.
I mean, if you think about the incidents that we see it on, CT and MRI when we're doing our routine imaging and we see sinusitis, and a lot of those kids are totally asymptomatic, but their sinuses look like totally packed in. So I agree with you. Like, how do you get to that number where these kids have true sinusitis versus this profound sinus congestion without symptoms? And why do some kids not have the ability to convert? Because I don't think I've seen an incidence increase of unimmunized children coming in with the empyemas. That hasn't been my, looking at it anecdotally, experience. But yes, the incidence is crazy higher. But it's interesting, who are the kids that convert?
No idea.
Any further questions?
Sam, can you hear me okay?
Yes.
That was terrific. I remember reading that South African series from ages ago, but it's the same one I remember, I think, from Durban. But was the in the craniotomy group, did it indicate how many bones they left out versus putting back at the time of the initial decompression? And if there was an increased incidence of then having to go back in and take out a bone flap because it got infected?
I don't remember, but it's a fantastic question. And something that I've thought about a lot with these cases is we're, doing a small craniotomy, we're devascularizing that bone, putting it back into an infected patient. Is that, the same as leaving in an implant in a patient that previously had an infected craniotomy? And I need to look at it more closely. It's a great question, and certainly surprising that we don't see more infections after replacing these bones, in a craniotomy or in a delayed fashion in a craniectomy, considering they're devascularized and infected. I don't remember from that paper, unfortunately.
My general practice has been to put it back because, assuming that they don't need it all for ICP purposes. It's just surprising how few I've had to then end up taking out for the reasons that you mentioned, because you'd be, really concerned about a foreign body, which a bone flap essentially is. So, okay.
Yeah, hey, Dave, to give you some contrast, where I was before, we had this protocol where the first time washout was a craniotomy and the second time washout was a craniectomy.
Yeah.
And then we tossed all those bone flaps. But that
Yeah.
was just like a routine kind of thing that we all did. And I don't know that anyone knows the right answer, because part of it is ICP, part of it is vasculitis, part of it is cytotoxic edema. It's like, I think it's multiple different physiologies like working against us.
Any other questions? I guess that's it. Thank you, everyone, for coming. Please reach out if you have any other questions, and I look forward to seeing you around. Thank you.
Thank you so much. Have a great
Thanks,
day.
Tim.